right, so part 2 for chapter 11. We are going to take a look at computerized prescriber order entry, or also known as CPOE. This is where the prescriber will directly enter the order into the electronic health record of the patient using either a mobile device or a laptop computer. The pharmacist will then check and verify the order. So this has eliminated the doctor handwriting the orders, sending it down to pharmacy inputting it, and then being verified by the pharmacist. So a lot of times, especially with doctors, their handwriting is atrocious. It's very hard to understand what they're asking for. A lot of medication errors are made because of the incorrect interpretation of the handwriting. So the electronic process now allows the physician to put the orders in directly for the patient through the computer, which eliminates that illegible handwriting. The pharmacist will then check it and verify it and proceed forward with it if it is okay. So the advantages of CPOE: efficient medication order completion, allows for the prescriber to enter off-site. So let's say the nurse calls in the middle of the night and the patient needs an order for something, the physician can do it from home. It simplifies the inventory ordering and posting of patient hospital charges. So for billing purposes, it absolutely 100% improves medication safety because it reduces transcription errors. And it also includes safeguards that identify either duplicate drugs that have been prescribed, incorrect doses, and lab test results that may affect the drug or their dose. So when the pharmacist is verifying all of this, there's warning windows that will pop up saying duplication of therapy, or this drug is contraindicated for this particular patient, or this patient's on another drug that may cause an interaction, or the patient's allergic to this medication. So there's a lot of different safeguards. Handwritten orders are in some facilities, most have gone completely electronic, but there may be some, especially in some rural areas, that are still using handwritten orders. These have to be input by the pharmacist into the pharmacy software and then verified by the pharmacist for accuracy if it's a technician that did the order entry. So it says, as of 2014, almost 60% of hospitals had already adopted the CPOE. So imagine by now that number is probably significantly higher. So the electronic medication record, or known as EMAR, an electronic record of the administration time of each drug. This uses the barcode technology that is on their wristband, which is known as barcode point of care scanning, or BPOC. This again is used to reduce medication errors and increases the productivity of nurses. The benefits of EMAR: enhances the communication among the entire healthcare team members, it reduces medication errors, and it provides a way to meet documentation guidelines. So not only do the nurses have to give the medication, but they have to document what medications are given at what time. And when they do this, the barcode scanning, they scan the patient's barcode, scan the medication, it automatically makes that documentation for them. So filling and delivering of medical or medication orders. So unit dose, and if you're looking on slide 31, which I encourage you to because it shows photos, so it helps give a visual of what I'm talking about. Unit dose is a dose of drug that is repackaged for a single administration to a particular patient at a particular time. It is stored in pick stations for cart filling. Advantages is it streamlines the workflow, it decreases medication errors, and helps reduce waste. So let's say we have a bulk bottle of 500 tablets. We can individually unit those into single doses that we would dispense out to the nursing units. The unit dose cart is a movable cart with removable cassette drawers for medications for all patients on the nursing unit. I can tell you that in Tucson, none of the facilities have the medication carts anymore, maybe nursing homes, but the major hospitals do not. They use the automated dispensing units. But back in the day, this was the way that we dispensed the medications to the patients on the nursing units. And these were stocked and maintained by technicians. Robotic filling. Some facilities have robots and some don't, but they are used to pick, count, package, label, store, and dispense medication using the barcode technology. The dispensing process, so the medication is selected by the robotic arm. It is transferred to the collection area. It's then put into an envelope. It is labeled with the patient's name, the drug name, the dose, the administration time, and the barcode. It is checked, so the technician will scan the barcode by as the technician for a check. It is added to the unit dose cart, and then it is checked once again by the nurse by scanning the barcode just before administration. So a unit dose system versus a robotic system. So the advantages. So the advantages of a unit dose system: a streamlined workflow process, a decrease in medication errors, an increase in medication security, a reduction in medication waste, and then an increase in cost effectiveness. The advantage of a robotic system is further decrease, an additional decrease in medication errors. It helps reduce the pharmacy overall workload, and it is an increased long-term cost savings. So the disadvantages: so a unit dose system is not automated, so that's a disadvantage. And then with the robotic dispensing system, it has a very high short-term cost. So the initial cost of purchasing, training, and getting it up and running is very high, so that's a disadvantage, but it eventually pays for itself in the long run. So not all drugs and doses are commercially available in a unit dose form. So that's when I was talking about buying a bulk bottle and transferring those into single doses for patients. So they must be repackaged, and they must be labeled carefully and documented in a repackaging control log. So not only are you repackaging them, but you're also documenting the information into a control log. So both the technician who does the repackaging and the pharmacist who is checking the repackaged product must initial the work log. Stocking emergency drug crash carts and drug box. So your crash cart is a mobile cart that holds necessary drugs for an emergency code, such as a code blue. An emergency drug box are used by paramedics, and they are both stocked by pharmacy technicians and verified by the pharmacist. So certain ambulance companies have contracts with certain hospital facilities. They will bring their emergency boxes to the pharmacy and have them restocked. So stocking the floor stock automating dispensing cabinets, or the ADCs. So ADCs are secured lock cabinets of designated drugs on the nursing units. And it's an extension of the unit dose delivery system. It has touchscreen technology. Each dose is matched with a patient's medication order, and the whole entire system interfaces with the pharmacy's automated dispensing system software. So when that interfacing happens, it allows us to see what patients are on what units, what medications are entered in for that patient, and when those stocks hit par levels of a low, we know that we have to restock that. Clean room services, so intravenous admixture service, so safe and accurate preparation of parenteral medication. So remember, parenteral means injectable medications. Admixtures are prepared in a sterile clean room. We have to make sure they're done that way. Sterile garb and aseptic technique is required, and technicians are typically the ones that specialize in these tasks. Total parenteral nutrition, known as TPNs. These provide nutritional needs intravenously for patients who cannot or will not eat. There's a complex compounds that are contained within the TPNs that contain many ingredients, from amino acids, fats, sugars, carbohydrates, vitamins, different things like that our patients are going to need. Automated sterile compounding systems can prepare common TPN solutions. And if it's a smaller facility, they may actually outsource their TPN admixtures to other local compounding pharmacies. Inventory. So up to 70% of the pharmacy's budget is spent on drugs. So the budget can include IV solutions, sets, pumps, and other medical supplies in addition to the drugs. The buyer, which is often a senior technician, manages the inventory, and they work under the supervision of all of the pharmacists, but in particular the director of pharmacy. Bidding pharmaceuticals and purchasing contracts. So confidential process by which the pharmacy will lock in medication costs from their prime wholesaler vendor for one entire year. The pharmacy will also bid with manufacturers of drugs and IV solutions for longer contracts. So let's say we are using Baxter to order our IV solutions from. The purchaser can negotiate a contract longer than a year, up to 5 years. The buyer will make accurate estimation of the formulary medication use for the next calendar year, which is then given to the director of pharmacy to help planning for the pharmacy's budget for the next year. Ordering of pharmaceuticals. So hospitals will order from wholesalers such as McKesson or Cardinal Health, ABC, which is AmerisourceBergen. There's a lot of different pharmacy wholesalers out there that facilities will use. TMC may use a different one than UMC, so it's not an all or one type of thing. IV solutions are ordered from a medical device company such as Baxter or Hospira. Procedures for ordering non-formulary drugs and borrowing from other facilities will vary from hospital to hospital. So we can, let's say I'm a pharmacy technician at Tucson Medical Center or TMC. We have a patient that came in with a rattlesnake bite. We have no more antivenin. I can call the other local hospitals here and borrow that medication or that antivenin from them. Now, how the procedure is different from every facility. So that's something that you will learn when you get into that role. But it's important to understand that we can borrow medications from other facilities if needed. Receiving and storage. So your inventory control tech will order the medications, and all technicians will assist in the receiving and restocking of the orders. You'll check the order against the invoice upon receiving the order. Again, you must make sure that everything that was ordered was in there. You're going to check for anything that may have been damaged. You will check for items that were not received because of maybe a back order or a drug shortage. All drugs should be placed on the inventory shelves or in the refrigerator, wherever they're needing to be stored appropriately. Storage guidelines are available in the package inserts of all medications. So if you're unsure, you need to check the package inserts on where to store that medication. Handling of certain pharmaceuticals. So for example, narcotics. Schedule 2 drugs must be ordered using a DEA Form 222. There is an online ordering system that is DEA approved called the Controlled Substance Ordering System. Not all facilities have access to that, but it's important to understand that technicians cannot order C2 meds. We can order C3 through 5, but only pharmacists can order C2s. Physical inventory of C2 medications must be done every 2 years as required by the DEA. Destruction must be witnessed and documented. Your investigational drugs must be separate and stored in a secured area. So investigational drugs cannot be stored with all of your regular pharmaceuticals because these have not been approved by the FDA. These investigational drugs are supplied directly from the manufacturer that is doing the investigational drug study. They are not usually labeled with a name and strength. It's usually numbers and letters, and the package is labeled. All packages are labeled with a lot and expiration date. So performing your ongoing inventory responsibilities, rotating the inventory, rotating stock. I cannot express this enough how important that is. Make sure your stock is getting rotated. Checking for drug recalls. You've just done an activity on that. You'll receive a recall notice from the wholesaler or the manufacturer or the FDA. It will list the drug and the lot number and the expiration date in addition to its NDC number that is being recalled. You will pull it from the shelves. You will check everywhere in the facility, the hospital that you're storing drugs, to make sure that all has been removed. You will complete and sign a return form to the wholesaler to receive credit, and then that form is then kept in the pharmacy. So other institutional pharmacies, so for example, long-term care facilities, sometimes they have pharmacies on site, sometimes they don't. Most of ours here in town do not. So there's little satellite pharmacies, Farm Care, Spectrum, First Care RX. These are very small pharmacies that only fill prescription for long-term care facilities. Joint Commission. Joint Commission is an accrediting body, and they set the standards for quality and safety of healthcare for accreditation and reaccreditation purposes. It includes best practice to reduce medication errors and address any patient safety issues. Accredited hospitals may receive reimbursement from Medicare, Medicaid, and other private insurance companies. Now, the important thing to understand is Joint Commission is a voluntary accreditation. However, if facilities want to receive reimbursement from Medicare or Medicaid, which is from the government requires that the facilities are Joint Commission accredited. And a lot of private insurance companies are making that requirement as well. Medicare will no longer reimburse hospitals for the additional cost of treating preventable infections, injuries, medication errors, or preventable readmissions to the hospital. So what does that mean? Let's say that a patient came in for surgery. They should have only stayed in the hospital for 24 to 48 hours, but they developed an infection post-surgery. The insurance company, particularly Medicare, is not going to cover that because they see that as the fault of the hospital. So the costs that are incurred for the infection have to be eaten by the hospital. They cannot charge the patient for it, and the insurance company will not reimburse. The on-site Joint Commission survey, it's an unannounced visit. It is multiple days, and they do it right on site. So it's a survey team that shows up at the facility. They are evaluating the hospital's overall performance. They're reviewing all P&P manuals, policies and procedure manuals, and they are actually interviewing hospital staff. A summary report is given to the hospital administrative staff at the end. What they're looking at is dings or violations they found, or if things were in working order, and the final report is then available for public to view online. Setting national quality standard of care. So the Joint Commission sets the national quality improvement goals for raising patient care facility quality nationwide. For a select at-risk patient population, so such as patients that have had heart attacks. The clinical pharmacist in the hospital will measure the institution's progress towards these specific patient care goals, and the technicians could be asked to help gather that information. So productivity tools are used to strive to measure improvement of patient outcomes and help lower the cost of patient care. So measures include the number of medication orders entered that are verified or discontinued, that patient profiles are continuously reviewed, progression notes or progress notes are made by the clinical pharmacist. Any adverse drug reaction reports are investigated, and then handled to make sure they're prevented in the future. Participation in CPR codes, and then looking at error rates. The data collected through the electronic health records. The data is collected specifically through the electronic health records and the pharmacy's informatics systems. And that completes Chapter 11.